Hello, everyone. Welcome to the last session of the public health surveillance course. On this session, we will continue the last session about the epidemiologic use of surveillance data by Dr. Nash. A brief introduction of myself. I'm Jenny Shen. I'm a PhD candidate in the epidemiology and biostatistics program in the School of Public Health. I'm also a data analyst at the Institute for Implementation Science in Population Health at the City University of New York. Firstly, we want to have a brief review of last session. Just as Dr. Nash explained, that surveillance data is a very helpful resource, but it is often an under-tapped source of data for additional epidemiologic analysis. There are many advantages of this data sources. It can help set research priorities. It can also be leveraged to assess effectiveness of policies or programs, and also to use to assess other causal associations. Key characteristics of this data source is that we often use it to complement with additional existing data sources. And of course, we also need to understand what's the limitation of this system, whether they are enough to answer the planned analysis and research questions in your first step. And to encourage us that there are a lot of creativities, the room for creativities for us to think about the usage of these data sources. Let's briefly review what's the steps to start an analysis. And it's always started with a very well-defined and articulated research question. And whether the examples are, maybe you want to assess the effect of a new program or policy, or you want to identify some mediation impact or of disparities, for example. And then you need to have a good understanding about what's the strengths and limitation of this data in hand. And by doing this, you want to well define what's exposure, what's your outcome, what kind of measurement you want to assess to address the question in your first step. And then according to the goal, the aim of the analysis, you want to design your table shell and design the measurements such as association or some descriptive measurement. The examples including such as you want to examine the trends of certain event due to a certain disease. And you also want to identify and describe the demographic factors associated with this event. You may also want to define that certain intervention exposures and its associations with the outcome. And then you can get started with some exploratory data analysis. And in the steps, just always think about what's your question, what's your exposure, outcome, association of measurement. But during this process, you also want to think about, ask the question to yourself, are these data sources kind of enough to answer the question you planned in the previous steps? And are this data clean, and what kind of steps you need to clean this data? And are there missing data challenges? And what kind of data visualization tools you can use to make this data more accessible to the audience? Yeah, the goal of this session is that we want to explore more examples that apply and use surveillance data to answer epidemiological research questions, and to kind of inspire and encourage us to after this course, you can conduct your own research paper and analysis. We want to work through these examples by the steps of how to articulate and refine epidemiology questions, and how to define outcome, exposure, associative measurement, or descriptive measurement. and how to understand the database strengths and limitations to answer this question, and also how to develop your analysis plan, design your table shell, and the visualization tools. The first example is that Dr. Bro in this paper use surveillance data combining with the other data sources to answer the question that what's the causal impact of police killing of unarmed Black Americans on self-reported mental health of other Black American adults in the US general population during the year of 2013 to 15. And the data sources of this analysis are done by combining or say merging of two databases. The first one is the US Behavioral Risk Factor Surveillance System, what's called BRFSS. This is a powerful tool for targeting and building health promotion activities by collecting behavioral health risk factors at the state and local level. And this questionnaire is the nation's premier system of health-related telephone service that collects state data about US residents regarding their health-related risk behavior, chronic health conditions, and use of preventive service. This database was originally established in the year of 1984 with 15 states, but now it collects data in all 50 states, as well as the District of Columbia and the 3 US territories. And this survey completes more than 400K adults interviews each year, making it the largest continuous conducted health service system in the world. To do this analysis, they also, Dr. Bro also combine this powerful tool with another database. It's called the Mapping Police Violence Database. This database is have been tracked police killing in the US since the year of 2013. And the reason to kind of establish this database is to address a concern about their probably underreporting in the police killing by the government statistics. So the database tracked the suspected killing, cross-checked against the police and criminal records, social media, and arbitraries. This database includes information on age, race, sex of the victim, and also about whether the victim was armed, such as whether there is any weapon that could be used to harm or kill others. And also the location of the killing, where it's happened. And then what's the definition of the exposure? The exposure is defined as the number of police killing of unarmed Black Americans occurring in the 3 months prior to the exact date of the BRFF's interview in the same state up to and including in 2016. So the reason of including the year of 2016 is to better quantify the number of police killings occurring both before and after the interview dates. A few points to pay attention that firstly, this data is a cluster level versus in many studies it's using individual exposure level. There are reasons for this choice. Firstly, state level exposure is the minimum drug geographic level could be identified in the BRFSS survey. And also there are studies showing that state level exposure has the greatest impact on the residents in the state. So the analysis defines as exposed of any person living in the state where the police killing occurred includes some people who may not have been substantively exposed to police killing. or even aware of the cooling happening. So the choice of class level exposure makes this causal estimate be an intention to treat interpretation, which is similar to a randomized trial with non-compliance of treatment assignment. This method captured the aggregated population level effect, but probably underestimated the effect of polyschooling on the mental health of subpopulations who are most directly exposed and also have the potential to overestimate the effect of polyschooling on the mental health of the population who were unaware or the least impacted by the polyschooling. The outcome is defined using the data happening in the year of 2013 to 2016 BRFSS among the Black American respondents to report their number of days in the previous months in which the respondents' mental health was reported as not good. The original question was worded as in the survey, they asked the respondent that now thinking about your mental health, which includes stress, depression, and problem with emotions, for how many days during the past 30 days was your mental health not good? As we explained, this survey has been conducted for very long, so there are many studies has been used this tool to establish the mental morbidity, and it has been shown that this tool have a high degree of internal validity, construct validity, criteria relative validity, and retest reliability. It has been widely used in literature to monitor trends in population level mental morbidity. The outcomes variables defined in this paper were defined as the first is the primary outcome defined as the poor mental health days. In addition, they also define two secondary outcome variable. One is the binary variable is any poor mental health days happening during this period of time, and also the frequent mental distress, which is defined as whether or not an individual reported 14 or more days of poor mental health in the prior months. And this measurement has been also widely used to quantify the population prevalence of frequent mental distress because it correlates with severe mental health conditions. The measure of associations in this paper, because this is as we explained the goal, this is a causal effect measurement. So we need to define what kind of association measurement. Because of all the models was estimated using standard BRFF survey weights, so they were able to account for the survey design and differential non-response. Under this weighted design, that the two association measurement was conducted. One is the rate difference for the primary outcome using the difference in difference multivariable regression models. And the second is to the relative risk for primary and secondary outcome using the robust causal models. In both analysis, they adjusted for the confounders of year to month, day of week, fixed effect, and also the demographic factors of age, sex, and education. Just a brief explanation why they need to adjust for year to month, day to month, and day of week fixed effect because of their, by hypothesis, their potential have been the national secular trends in outcome, or there probably will be state-specific seasonality in mental health, or the day-to-week seasonalities in the mental health of the people under the study. So it's important to adjust these factors. And as shown in these two tables, we can see that the mean age of the respondents were 45 years with the standard deviation of 17. And after accounting for the sampling weights, approximately half of the respondents were women and half had completed university. Respondents experienced on average of 40.1 days of poor mental health in the months prior to interview. And there were 38,000 people Black American respondents were exposed to one or more police killing of unarmed Black Americans in their state of residency in the 3 months prior to the survey, which account for about 49% of the entire sample. Also, as shown in this data, that the range of the police killing was 0 to 7, and descriptive of the victim has been shown here in the table 2. So in this figure that Dr. Bro presented the changes, the number of poor mental health days in the 6 months before and after exposure to the police killing of unarmed Black Americans. So this figure actually displays a coefficient association that also with their 95% confidence interval. The reason for the presenting 6 months before the police killing is to establish the negative control to see if there is any falsification issues in this data. So we can see the largest estimate corresponds to the police killing that occurred actually happened 30 to 60 days prior to interview. So that each additional police killing during this time window was associated with 1 to 3 more days of poor mental health. And the next significant data is the 1 month after the killing. That is only half of the 30 days record period occurred after exposure. So the respondents reported 0.1 additional days of poor mental health per each additional killing. In this table that this presents the changes in poor mental health days associated with exposure to police killing by a few factors measured. The primary outcome is presented at the top, that each additional police killing of unarmed Black American was associated with 0.14 additional poor mental health days with the 95% interval, confidence interval between 0.07 to 0.22. As shown in the previous slide, the largest effect on the mental health occurred in the 1 to 2 months after exposure. As a conclusion, overall police killing of unarmed Black American contribute 1.7 additional poor mental health days per person year, which will translate into the population of 55 million days per year among Black Americans. Compared to how diabetes is impacting poor mental health days, that is 70 million poor mental health days per year among Black Americans, we can see how severe the police killing of unarmed Black Americans contribute to this population level poor mental health days in general. This example of how to combine with this well-established surveillance data with the other data resource of the exposure of police killing of unarmed Black Americans to deliver a message how the causal association is to event. And the second example is by Dr. Robertson to assess the effectiveness of an intensive HIV care coordination program on the outcome of durable viral suppression among people living with HIV. In the last session by Dr. Nash, he presented an example by Dr. Irving about the outcome of this program. So let's firstly briefly review what is this program. This program is called HIV Care Coordination Program. It was established in the year of 2009 by DOH of NYC. They began by implementing this program at 28 Ryan-White funded agencies. This program targets patients as high risk for suboptimal HIV care outcome, including those who are out of care, those with a history of irregular care, or those with having difficulties with medication adherence. This care program combines various evidence-based programmatic elements into a package that includes case management, patient navigation, directly observed therapy, structured health promotion in home field visit, and outreach to assist patients in accessing needed care and related service. And the intensity and the focus of this service can be tailored to meet individual needs. To be noted that this program was rolled out purely as a service outcome, program, so there's no randomization or comparison groups, including as the clients of this program. So as shown in this figure, there were already 28 agencies and their affiliated service site against a map of HIV prevalence in the NYC neighborhoods. As you can see here, program locations are located in the neighborhoods with the highest HIV prevalence across all 5 boroughs of the city. The data sources of this analysis, similar to the first example, they're also combining or merging 2 databases. The first one is the CCP programmatic data, which is drawn from the DOH electronic system for HIV/AIDS reporting and evaluation. And the participants were enrolled between 2009 and 2013. And the second data source is the surveillance data. The HIV surveillance registry contains demographic and clinical information on all diagnoses of HIV reported in NYC. And the registry data has a comprehensive HIV-related laboratory reporting, including the CD4 and viral results for individuals who have received HIV medical care in New York City. And there are also vital status information, which is updated through regular matches with the death data. So compared to example 1, that both kind of merging, combining 2 data sources, and what's the difference? So in example 1, you can see that the exposure of exposed and unexposed are all included in the police killing database. But in this example, that exposed people are all the people who enrolled into this CCP program. But now we are going to establish a group of people who were unexposed from another database. So the differences comparing to this example is that now we need to find a way to establish the comparison group. There are a few steps here. The first one is to identify the non-CCP program people living with HIV who could have been enrolled into the CCP between this group of people. That means they were kind of raising from the same population from the CCP clients during this period of time. And secondly, they were randomly assigned with a pseudo enrollment date that fell within their eligibility windows as those CCP clients. And next step is to restrict to persons with at least one viral load in the months of the first 1 year after enrollment or the pseudo enrollment. And also greater than equal to 2 viral loads in the months 13 to 36. By applying this criteria, that means we need to have a minimum number of viral load as a proxy for ongoing receipt of NYC HIV medical care to prevent there's a potential of differential effect out migration. So imagine if people who have less frequent viral load assessment, that means they will probably move out of New York City or kind of not comparable to the CCP clients, because to be eligible to be a CCP client, they have to be residents in NYC and also receive more frequent service care. And the last step is to match the CCP enrollees to the non-CCP people living with HIV on their, firstly, the criteria, their enrollment, pseudo enrollment date, and also their baseline treatment status, the propensity for the CCP enrollment. I just want to explain this baseline treatment status in more details. So when people kind of enrolled into the CCP program, they have different risk and in the 12 months prior to their enrollment. So people can be newly diagnosed, or they have very good consistently viral suppressed. That means their disease is well controlled. And there also can be no evidence of viral load suppression at all. That means their disease is not well controlled. And or they can be in the between. They have inconsistently suppressed. That means, yeah, they were kind of in the borderline of suppression. The outcome of this study was defined. Firstly, the follow-up period is between the December 1st, 2009 and March 31st, 2016. And the durable viral suppression was defined as regular viral load monitoring, and all viral load was less than 200 copies per milligram per milliliter in the months 13 to 36 of follow-up. There is also a secondary outcome that is defined to have ever having viral load suppression after enrollment. So basically 2 outcomes. One is the more desirable outcome is a durable viral suppression. The other one is just ever having a viral load suppression. And the major association that the first one to record that in this analysis, we're aiming to assess the effectiveness of a policy or program on certain outcomes. So this is like a causal effect. So we want to measure if there's any association. So the first association measurement is the relative risk, which is the risk ratio for the durable viral load suppression by using log binomial regression model. And another association measurement is the odds ratio for not experienced durable viral suppression among the CCP enrollees by using the logistic regression model. Through an intention to treat approach, the authors examined the effectiveness of the CCP on the outcome. they use this model counting for the match design and modeled within each baseline treatment status group and overall. Additionally, they also assess whether the DVS increased with duration in the CCP. So the authors categorized the DVS outcome by the length of enrollment and then do the test for if there is any trend of this outcome. This figure shows how the matched CCP and non-CCP clients was selected for the study. So from December 1st, 2009 to March 31st, 2013, there were in total of 7,337 CCP enrollees. Of them, there were 7,058 were alive in the 12 months post-enrollment. And then the next step, there were this number of people who had evidence of medical care in NYC. So eventually the CCP clients number were 6,207. In the registered data applying to the steps, we explained before that they were able to match the same number of 6,207 people. And so among these people, they compared their measured characteristics after the match. All the characteristics were similar of these two groups. So this table that the authors examined the association for the exposure and the outcome. So from this one, we can see there are only 37 of the cohort ever experienced the outcome of durable viral suppression in this period. And the proportion varied greatly by their baseline treatment status, basically their risk. And you can see that the highest suppression was happened among the consistently suppressed group, which consistently suppressed at baseline. And the second highest is happened among the newly diagnosed people. And so the lowest is happened among the no evidence suppression baseline at all. So in this analysis, we can see that CCP enrollees with no evidence of the viral load suppression in the year prior to the enrollment was significantly more likely to have durable viral suppression compared to their non-CCP counterparts, with a risk ratio of 1.16, and their confidence interval includes not include 1. Similarly, among the group people who were inconsistently surprised, the CCP enrollees has a 0.67 risk of durable viral suppression compared to their non-CCP counterparts. And you can see that among the newly diagnosed people and consistently suppressed people, there were no effect of whether they enrolled in the CCP program have an impact on the durable viral load outcome. In this table, that we can see how the days enrolled into the program have an impact of the outcome, the durable viral load suppression outcome. So people newly diagnosed or always suppressed were enrolled longer in this program compared to people who have no evidence of suppression and inconsistently suppression. So DVS increased, you can see the proportion increased with the the duration of their enrollment in this program. As a conclusion, that enrollment in an intensive intervention modestly improved the outcome on durable viral load suppression only among those unsurprised before the CCP program enrollment. So this conclusion actually shows promise to meet treatment as prevention goal to advancing progress among HIV continuum. So especially among people who without evidence of viral load suppression are prioritized for the CCP enrollment. After the two examples exploring the causal effect, the last example of this session is going to answer a question about surveillance of the prevalence. So in this paper, Saba Krasmin assessed the true prevalence of SARS-CoV-2 due to the changes in testing practice and behaviors, including increasing at-home testing and decreasing healthcare provider-based testing. They estimate the prevalence of SARS-CoV-2 infection during the preceding 14 days before the cross-sectional survey that is actually happening as the second Omicron surge in the spring of 2022 in New York City. And the data sources for this analysis was also combining from different sources. And one is a cross-sectional population representative survey that was conducted between April and May 2022. This survey used a platform that established a population representative weight of the people enrolled into that platform. And they used the text messages sending using certain platform. So briefly, the respondents can get a personalized first name text message, which includes a link to the survey. And also they have an opt-out option. So the respondents have the option to reply to the questionnaire. The data was verified by their IP address, and there's also another interactive voice response message sent to the landlines. The respondents were able to answer survey by using the touch tone keypad on the phone. In general, that this is a very good platform to conduct population representative surveys. The second resource is the DOH SARS-CoV-2 routine testing and case surveillance database. This database was established using the data provided by the healthcare provider and testing provider reported to the DOH on a regular basis. The third database is the SARS-CoV-2 concentrations in NYC wastewater by the water resource recovery facilities. This database kind of collect data at least twice each week, and they collect data as per capita of SARS-CoV-2 load as the protein copies per capita, so reported to each sample date. So remember, this is a prevalence estimation. There's no causal estimation in this paper. So, but we are going to examine the prevalence estimation by each of the data sources. The first data source is the survey data. From here, you can see what's the prevalence estimation that is estimated of 22% respondents had SARS-CoV-2 infection in the 14 days prior to the interview. which corresponding to 1.5 million adults. However, even though the estimation is 1.5 million adults, in the official MIC case reporting system, there's only 51K cases, that means our estimate, the survey estimation is actually 29-fold higher than the MIC case reporting count. In this survey, there are only 43% of the adults in the survey report having received a SARS-CoV-2 test with a provider. So you can see also the breakdown by how this prevalence is broken down by the confirmed, probable, and possible cases definition. And this survey also be able to assess the use of oral antiviral. Firstly, they assess whether they were aware of there is a medication that could be used to lower the risk of mortality and hospitalization. So you can see the awareness is very low in this sample. And also, even though the sample size is a little bit small, but they're still able to establish who were more vulnerable to very low to antiviral uptake. People with the Hispanic and non-Hispanic Black race ethnicity, those without health insurance, and those without college education had significantly lower antiviral uptake. So remember, the second source is the prevalence estimation by the DOH surveillance data about their number of tests conducted by PCR and antigen tests, and also was the number of cases testing positive during this period of time. This plot presents the data since the start of the pandemic, and also including the study period in this analysis. So we can see PCR test was the predominant test type reported, comprising of 63% of all positive tests. And even during the period of time of later in the study, in the pandemic, there is still predominant tests to be conducted and reported in the surveillance data. So we can see that during the BA2 period of time, there was substantial declines in the SARS-CoV-2 testing for 100,000 residents leading up to the study period. During the study period of April to May 2022, there were in total of 670K tests reported, which gave rise to 7.6% of positive cases. And the third surveillance database is the wastewater database. Is also an important tool to estimate what's the estimated prevalence of the cases. So the interesting finding is that the mean SARS-CoV-2 concentrations during the study period were modest compared to the BA1 period. However, when you calculate the ratios of SARS-CoV-2 concentrations to the reported SARS-CoV-2 cases, you will find out the ratios were really higher than the BA1 surge. This could happen due to a few reasons. It's possibly that the BA2 surge have the increased mean peak viral load per case, but it also could be due to the the cases is the reporting is not complete. So that means the denominator is underestimated, which lead to an overestimated ratio. So it's also be possible that if the people have the reinfection after BA1 surge, they may have results in a lower mean peak very low due to the greater acquired T cell mediated immunity. So this just gave us an example about how the prevalence estimation can be varied by the different method of conducting. If you do a survey-based data, you can establish possible, probable, and confirmed cases by you combining different sources of the test, such as the at-home test, which is not covered by the government registry data. But you can also have an estimation of the government case and reporting that is highly kind of influenced by the number of providers and testing providers available. It will be significantly biased if the number of testing providers are reduced due to certain reasons. And the third sources is the prevalence estimation by wastewater is a very powerful tool to more actively monitor what's the peak viral load by different time to give an estimation what the population prevalence probably look like. And so as a conclusion that when you conduct the analysis using surveillance data, what are the considerations you are going to think about? So the first is, what's the primary question you're trying to answer? And then to well define if this question is a causal question and what's the outcome to be defined in analysis, what's the exposures of interest, and both need to have a well-defined way to measure. And then you will think about what kind of measure association you are going to estimate. But as example 3, that if there is a no causal question, but you are more interested in presenting a prevalence, that you may want to think about the strengths and limitation in different data sources. You may to give a more full picture of what the prevalence probably look like. It's always an estimation. So to have a more robust estimation, you probably want to pull data from different resources. In this example, we have this population representative on cross-sectional survey. We can also use the government reported cases. We can also use such as wastewater, this kind of powerful tool to estimate. So no matter what kind of question you're going to ask, you will always need to think about what's the inherent limitation of the data you are using, and think about how to visualize the data to deliver the message you're going to convey. And also think about what analysis you're going to conduct, always from the simplest to the complex. What's the univariate analysis? What's the stratified analysis? And what kind of confounding factors are going to include in your model to estimate the multivariable analysis? So just to make a conclusion, that hope the session will give you a sense about how the undertapped source of data, the surveillance data, could be used for additional epidemiological analysis. So you always need to just set your research question, and that is a priority to be answered in public health area. And also it can be leveraged to answer more sophisticated causal questions.